Okay, so we've left it a couple of minutes for everyone to come and join us. So I think we will get started for today. Hi, I'm Maria and I'm one of the Health Promotion Officers for the HIV and Related Programs unit, and we're otherwise known as the HARP unit. We're based in Forbes Street in Forbes Street building in Darlinghurst. Before we do get started today, I would like to do an acknowledgement of country. I would like to acknowledge the traditional custodians of the land in which we live, travel and work on. I would like to pay my respect to Aboriginal and Torres Strait Islander people and to any past, present and emerging leaders. I would like to extend a warm welcome to any Aboriginal colleagues attending today. This always was and always will be Aboriginal land, and I'm very thankful to call this beautiful country my home for the last 11 years. A very warm welcome to all of our colleagues across the Southeastern Sydney Local Health District. Today we have a variety of staff coming from mental health, drug and alcohol, social work, infection control, public health and maternity. So thank you all for joining us today. Before we do get started, some housekeeping. All participants today will be on mute as a default setting. We do, however, have a Q&A box open down the bottom of your screens. Should you wish to submit a question, please feel free to do so. If we don't get time to get around to everyone's question today, I'll collate these questions, have them answered by our lovely panelists today, and email them out to you in the coming days with a link to our evaluation. Please be brutally honest in your evaluation. For those who don't know, today is World AIDS Day. World AIDS Day is marked every year on the 1st of December. It's been an annual event since 1988. People from across the globe unite on this day to show support for people living with HIV and to remember those we have lost from AIDS-related illnesses. The National World AIDS Day theme for Australia in 2021 is 40 years of HIV and where to next. World AIDS Day aims to encourage Australians to educate themselves and others about HIV and how to take action to reduce transmission of HIV by promoting prevention strategies and to ensure people living with HIV can participate fully in community, free from stigma and discrimination. The purpose of today's webinar is to explore the contemporary testing and treatment modes available to us, caring for those with HIV, and also to address the issue of stigma and discrimination people who live with HIV face within healthcare settings. Within our work, we are guided by the New South Wales HIV strategy, which sets out the goals and strategic direction of services such as the Southeastern Sydney Local Health District, Sexual Health and Bloodborne Virus Services. We are also guided by policies and best practice for testing of bloodborne viruses. I would now like to introduce Dr. Philip Reid. Dr. Philip Reid is the Sexual Health and Bloodborne Virus Service Director for Southeastern Sydney Local Health District. Today, Phil is going to be introducing us to the new bloodborne virus testing policy for Southeastern Sydney Local Health District. Thank you for coming today, Phil, and we're glad to have you with us. So Phil, can you tell us about this policy and how it guides clinical practice for testing of bloodborne viruses?
Yeah, sure. Look, thanks very much for the invite. It's a great honour to be here with my friends and colleagues who are the other panellists and to be speaking to other people throughout the district. Thanks for organising it. So, yeah, I mean, from my perspective, again, also welcome to the World AIDS Day event. And, you know, as the Director of Sexual Health bloodborne viruses, by which is meant HIV, hepatitis C and hepatitis B. And we're part of the Population and Community Health Directorate, so very much community-based services. So from our perspective, and I think from New South Wales Health perspective and nationally, HIV remains a really important and significant public health issue in Australia, and also, of course, a very personal issue for the sort of 29,000 people living in Australia with HIV at this time. So last year in 2020, in Australia, there were just under 700 diagnoses of HIV, so people diagnosed with HIV for the first time. And that actually is one of the lowest annual counts for quite a long time. It's of course possible that under-testing because of COVID and not coming to health services has impacted on that. But it may also be that, you know, our prevention measures, which I'm sure you'll talk about a little bit today, and our treatment as prevention measures, and also sex-related risk factors over the COVID period may have changed as well to impact on that. So I think you know, there's certainly some positivity in that story, or some good news in that story. Medically, of course, we've come an enormously long way in the management of HIV to be able to afford people living with HIV excellent quality of life and you know, near normal life expectancy in most cases. And of course, you know, the prevention space has been completely revolutionized over the last few years through the emergence of PrEP, but also reinforcing the importance of condoms and clean needles and syringes, and also the role of community and behavioral interventions in preventing HIV. But I think, you know, for many of us working in the sector, I'm sure it'll come up today, stigma and discrimination can be very real still, and has a powerful and significant impact on people's prevention and testing patterns, and also their engagement in care and in the broader community if diagnosed with HIV. And so I think, you know, those are really contemporary issues. They're still super important, despite the pleasing news about reduced numbers of diagnosis. We still need to have a focus on World AIDS Day. I think it is a very important and significant event, as Maria said, both to remember and honor the people that we've lost, colleagues, friends, the efforts that have been made by you know, the health system, most importantly by community members, by government, to try and get Australia into the position that it is. But also to look to the future and to think about, you know, HIV prevention, to think about living well with HIV for people that we know and love with HIV, and to make sure that there is an annual focus on HIV. And I guess, you know, that's part of the purpose of today. Now, Maria asked me to talk about the bloodborne virus testing policy, which we've launched across the local health district over the last few weeks. Now, the purpose of that, of course, is that although we have had a reduction in the number of new HIV diagnoses over the last few years, we're still diagnosing, as I said, last year 700, and the year before that almost 900 people with HIV. And almost half of those individuals, I think 44% last year, were diagnosed what we call late with HIV. So often there were missed opportunities. When we look back at those individuals' medical records, either with GPs or with interactions with our own health system, there were often moments where an HIV test could have been offered, but for whatever reason it wasn't. And then that person continued to live with HIV without the awareness that was something that they could then get treated for and manage, and without the awareness that it was something that they could potentially prevent transmitting to other people. So that's a large proportion of cases that we could probably diagnose earlier. And one of the aims of the New South Wales strategy in HIV, which has 3 pillars, which is testing, treatment, or early treatment, and prevention, or staying safe. One of the really important things there is testing frequently, identifying people early after they've acquired HIV, and then getting people supported to get onto HIV treatment, which, of course, as we'll probably talk about later, completely eliminates the possibility of transmission once an undetectable viral load has been reached. Now, so as a local health district, we actually have an HIV testing target. We engage with the Ministry of Health around HIV testing, and as a district, we do the largest number of HIV tests across the state. And our testing target as a local health district for the last few years has been in the order of 27,000 to 28,000 tests a year. Now, about 25,000 of those are done through the bloodborne virus and sexual health services, and the rest are done in other services. And in the New South Wales HIV strategy, we've called out a number of really important services where there's evidence that people living with HIV may attend, and there have been examples of where people have been missed for a little while and not offered a test. And So we've developed a bloodborne virus testing strategy to strengthen people's ability to respond to that and to provide guidance within all of the clinical services, both inpatient and outpatient and community facing, to be able to operationalize and support bloodborne virus testing. So here we're talking about HIV, but the policy itself is inclusive of hepatitis C and hepatitis B. So the policy runs to a few pages, so we will, I'm sure, send it around, Maria, and it's of course available on the intranet. But broadly, it identifies a number of risk factors for people living with bloodborne viruses that should prompt an annual test in anybody in any part of the health system. So even if bloodborne virus care isn't your core work, we're recommending that, or in fact, it's a policy, so we're wanting people to be offered HIV and bloodborne virus testing at least annually if they have a risk factor, and a lifetime test to anybody with historical risk factors as well. So we've called out a few settings. So the sort of settings that people with bloodborne viruses may transition through and are sometimes not picked up, and often they are picked up by fantastic clinicians, nurses, doctors, and social workers recommending tests, and counsellors and peer workers, but sometimes they're missed. And so the settings that are called out in the HIV strategy and in the bloodborne virus testing policy within Southeastern Sydney are places like drug and alcohol settings, people with risk factors for injecting drugs, people attending mental health services, particularly acute mental health services. There are a number of conditions where people may attend an emergency department where we know the prevalence of presenting with undiagnosed HIV is higher. And then there's a number of other examples that are given within the policy. And recognizing that in that policy, it's really important to give people a pathway with what to do in the event of a diagnosis. There's some clear advice about where support would be found for clinicians needing to deliver that result, and crucially for people receiving that diagnosis to know where their care is going to be provided and best managed. So I recommend that everybody has a look at this. We'll certainly be distributing it through the clinical streams. As I say, it applies to all settings, and we're really hoping that the policy will reduce the prevalence of undiagnosed HIV within people attending local health district settings, enabling people to get onto treatment quicker, have better health outcomes, and reduce transmission to others. So thank you very much for inviting me, and I look forward to the panel discussion.
Great, thanks a million, Phil. And it really just goes to show how important it is for testing within these services, because it could just be that one person that you just happen to offer the test to, and there you go. So I strongly encourage all of our participants today to take the time to familiarize yourself with the new bloodborne virus testing policy, which can be found on our intranet under policy, procedure and guidelines. And I suppose in the spirit of all the information, I can email out that BVV testing policy as a part of the evaluation link as well today. So now, without any further ado, I am absolutely delighted to introduce our panelists today. Today we have Maggie Smith, clinical nurse consultant from the Albion Street Centre, Joanna Politis and Alice Gibian, social workers doing case management with the HIV and outreach team, and the beautiful Dianne Nyoni, a person living with HIV and consumer engagement officer for the HIV outreach team. So we'll get started with our panel, and please don't forget at any point you can pop a question into our Q&A box and we'll do our best to get around to it. So Maggie, can you tell me what is the most up-to-date information about HIV testing and treatment in Southeastern Sydney Local Health District?
Sure. Thanks, Maria, for the question, and Phil for a really good overview. So I'm probably going to echo a lot of that. To discuss HIV testing, I guess we need to have a quick chat about what HIV is first. HIV stands for Human Immunodeficiency Virus. It's a virus that affects a person's immune system. It's transmitted or passed on through condomless penetrative sex, sharing of intravenous injecting equipment, or by a mother to a baby during childbirth or breastfeeding if the mother is not on HIV treatment. If left undiagnosed and untreated, HIV will weaken a person's immune system to a point where illnesses that would not normally be a problem can make them quite sick. That's what we used to call AIDS. We actually now call it advanced HIV infection. So there's a variety of ways to test for HIV. The one most people probably know of is a blood test collected from a vein, put in a little tube and sent off to the lab for testing. And that's the gold standard for testing. Other ways to test for HIV is a point of care test with the finger prick blood test or saliva, the dried blood spot test, or there's now actually home testing available in Australia. And the point of care test and dried blood spot tests have a longer window period of 3 months. And this window period I'm talking about is the amount of time it can take for HIV to be detected in a blood test. In Australia, all these point of care tests are good for screening, but are not considered what we say is diagnostic. So if any of these point of care or dried blood spot tests came back positive, a person is referred to a service, such as ours, for a confirmatory blood test, collection of blood in a tube and sent off to a lab. So people can test at home or actually have the opportunity to have their HIV result within 10 to 20 minutes. And hopefully all of these options help reduce a lot of barriers to people about HIV testing. And that might be distance from a place to test or fear of disclosure in a smaller community about why they might want to test, stuff like that. I think there's still lots of people worried about asking for an HIV test. Maybe they're worried about receiving a positive result, or possibly worried that the clinician will think of them or think strangely of them if they ask for a test. But really, HIV testing should be available to anyone who asks for one. And as Phil said before, there's certainly population groups in Australia who are more at risk of HIV, such as the gay male population. But really, if anyone's had a risk and are worried, they should go for a test. And as clinicians, if a person asks for a test, they should be provided with that test. Of course, there's certain times we should be concerned that an illness is an advanced HIV infection, and as clinicians be aware of those. But really what I'd like people to understand is most of the time it's about listening to our patients or clients, being non-judgmental, asking appropriate questions, and just being empathetic. People worry, I think clinicians worry about this whole consent process for an HIV test, but as long as the person knows what they're being tested for, how long they need to wait for a test is 100%, the window period, and advised of the follow-up process if a test is positive, that's all they need. And clinicians and people are scared of positive HIV results, and that's really understandable. But as Phil said before, it is far better for a person to know they have HIV and be on medication than not, but better for everyone. Most people these days are on 1 pill a day and reach what's called an undetectable viral load, which means we can't detect HIV in their blood test. And that means their HIV will not progress or cause problems for their health. And it also means they have zero chance of passing HIV onto another person. That's my wrap up for HIV testing.
Great. Well, you've given it certainly a very clear overview of the forms of testing that are available. And it's really awesome that, you know, science has come such a long way that people can even now do it from the comfort of their homes.
Yeah.
And I think this will really reduce some people's barriers to be able to access testing as well.
Hopefully.
So now that we've spoken about testing and treatment, I've heard a lot about some biomedical prevention. Can you tell me a bit more about that and what is currently used in our community?
Yep, sure. So what I'll talk about first though, even not biomedical, and when we use this big fancy term, basically it's using a medication to prevent, and in this case, it's an HIV infection. Condoms are still incredibly effective and cheap way of preventing HIV transmission and STIs and pregnancy. So let's never forget or downplay the role of condoms. But what you asked about is biomedical. So before, what Phil and myself talked about was a positive person being on their HIV treatment and an undetectable viral load being unable to pass on HIV. That's called treatment as prevention. And for HIV negative people, there's a couple of other options that people might have heard about for HIV prevention. HIV PEP. PEP is post-exposure prophylaxis, and HIV PrEP, which is pre-exposure prophylaxis. So PEP, the post, is taking a tablet a day for 28 days after a risk they're concerned about. So the medication needs to be accessed as soon as possible, within 72 hours, but the sooner the better. And HIV PrEP is taking actually the same medication, but before a possible exposure. And there's very good evidence that both of these strategies work really well. And both of these can be accessed through many GPs, sexual health services.
Maggie, if someone was to have an exposure and there was no sexual health clinics open at that time, could a person present to the ED?
Yep, really good question. And often these things, you know, sexual health services and GPs are often Monday to Friday business hours. And strangely enough, if it's a sexual exposure, these things don't always happen during business hours. So absolutely, any emergency department of a public hospital is able to start people on HIV post-exposure prophylaxis. And they would, certainly now there's a beautiful policy being launched, test that person for HIV as well as hopefully other bloodborne viruses at that presentation. So absolutely, if you can't get in, you know, if it's after hours, go to an ED of any public hospital.
Great, thanks Maggie.
Thank you.
Di, thanks for coming to join us today. So with yourself as a person living with HIV and a consumer engagement officer, can you please tell me about your role and how important peer support is for people living with HIV?
My role primarily is to support the consumer advisory group. We have 8 people currently on our group who are long-term survivors and come from various backgrounds. We are fortunate to have Indigenous people. We are fortunate to have women, men who've been living with HIV since the beginning of knowing about HIV. So very experienced panel of people. And so we want to make sure that we ensure that not only is the voice heard, but our service provides as a informed service. So the service that we're providing is what the people are wanting, more than what we assume they want. So in that we're very engaged, our consumers are very engaged in assisting with the design and development. So co-design is very real, and also supporting any new directives and directions, policies that are being made within the service. So I get the honour to support these wonderfully amazing people who have extensive stories, extensive knowledge, and who mentor me as much as I support them. And I also get the opportunity to be a voice for my community. I've been living with HIV for more than 20 years now. And it's a real honour to be able to bring their voice to us so that we can make sure that we meet the principles that the HIV community set out right at the very onset of HIV, and they are MEPA, that there is no actions being taken without the voice of the HIV people. And so that's something I'm very proud that SESLHD is doing and that the HIV team is doing in the HIV services.
Great. And Di, as yourself as a person living with HIV, having that sense of connectedness with your community through this role, do you feel that's really important?
I don't know how I muted. Can you hear me now?
Yeah.
Sorry, I don't know how that muted. Definitely, it's very, very important. And I think that lived experience means a lot to the people that I'm speaking for and in supporting the community. I think often, because I also was one of those late diagnosed, some of the things that I'm experiencing now with my health are very similar to those that the early long-term survivors have been experiencing also. So we've been a great support to each other, and there's a level of understanding that can only be experienced from going through that experience.
Absolutely. Well, thank you again for being with us today, Di, and I'm sure we'll be chatting a bit later on with some more questions.
Sure.
So Joanna and Alice, both social workers working as caseworkers on the HIV outreach team, thank you so much for being with us again today. So can you tell me, what does working with someone with HIV in the community look like? What's your day-to-day?
Thank you. Thanks, Maria. I suppose, look, our day-to-day work is very varied. So our team, the HIV outreach team, we're a community-based outreach service that provide case management for people living with HIV anywhere in SESLHD. So I suppose the key principles for our model of care are community outreach. So we meet with clients wherever they are in the community. We work towards integrated care. So we support clients to be able to access well-coordinated care that meets their needs. We focus on client self-management. So we actively support clients to set their own holistic goals and work slowly towards those. We also focus on timely and equitable access to care for all. So we do a lot of advocacy in trying to reduce practical barriers to important care and services. So we work from a very strong client-centred and at times trauma-informed approach. So this is really important to try and empower our more disadvantaged clients. So we engage and work alongside positive people to meet a very broad range of health and psychosocial goals, and like Phil referred to be able to live well. So I think there was a little question on the side there, Maria, about challenges that have been coming up with COVID. So just in brief, we have had, like everyone, lots of challenges there. I suppose we've found our clients have been even more socially isolated than usual, and have had a lot of increased anxiety and mood difficulties on top of their other health stresses. They've needed a lot more advocacy and support around communication, around technology, being able to access ongoing care, and that's been challenging for some because of perhaps lower skills or maybe cognitive difficulties. So we've really we're working hard to try and help them keep accessing the good care that they need.
With your setting of, I would imagine, goals with your clients, as you said that you're setting realistic goals, I would imagine when they do achieve them, that just must be a wonderful sense for them, that they're active members in their community and they are leading a normal life in a sense. How do they, can you pass more comment on that?
Yeah, so I guess sometimes I guess we look at what sort of goals, like sort of, I guess, shorter term goals that clients may raise that they're interested in working on, as well as, I guess, some longer term goals. And I guess we try and break that down and work on some of the practicalities of that, but still maintaining, I guess, some of those wishes and desires that they might be looking at as well to improve, I guess, their quality of life. So I guess there are some specific needs that our clients have in terms of their physical and psychosocial issues. So I guess we do face challenges in that area. So I guess physically, I'm not sure how many people know about sort of what I guess people living with HIV might be dealing with at this point in the epidemic. So I guess our client group, I guess, is primarily male and aging in a nutshell. So our largest age bracket is aged between 50 and 70. So those diagnosed during the early days in the 80s and the 90s are at higher risk of serious health problems. And many aged over 55 are living with at least 2 or more physical comorbidities. So some of these comorbidities are due to the HIV virus itself, but some are linked to previous treatment side effects, sort of normal aging processes, and lifestyle choices as well. So compared to the general Australian population, positive people have much higher rates of mental health issues, diabetes, heart disease, neurological disease, cognitive impairment, cancer and bone disease. So that's a pretty long list. I guess high lipids, altered body composition, smoking, alcohol and substance use is also, significantly increases their risk factors for health. So I guess you can kind of imagine that our clients access a really broad range of healthcare services and systems. So a client of mine, for example, regularly sees 4 specialists at different facilities in the area, as well as his GP for care. So, you know, there's often a lot of confusion about frequent appointments, and I guess that challenges us to help coordinate communication between such a large team and make sure that there's not misunderstanding. So I guess psychosocially, our client group is very diverse, as I think Di was referring to, but I guess it is fair to say that most of them face some psychosocial disadvantage. Many clients experience real social isolation and may not have strong family support. A fair number have experienced some past trauma and also have different types, I suppose, of previous grief and loss in their lives. So many can't maintain regular employment, rely on Centrelink income, live in social housing or temporary housing, and some face homelessness. So some receive NDIS support to stay at home, and others might be able to access my aged care. So informal and community supports are often very important. So that might be friends, peers, or community organisations. So I guess that's a little bit of a nutshell. I guess all of these factors, I suppose, can lead to challenges in clients being able to engage with the mainstream health services, and also at times difficulty managing their medical care and treatment.
Well, I was going to ask, and I would imagine supporting people living with HIV in the community can be quite complex. And I was going to ask about, you know, other services that are involved with your clients. And you did previously mention some, you have a client that sees up to 4 specialists, and, you know, I could imagine that could be quite, you know, difficult for them, and keeping track of all of their appointments then as well. So is there any other support services that you guys are involved with, and I suppose work a part of maybe a multidisciplinary team for your clients?
Yes, we have a huge list of services that we network with and try to work with, because as you know, our clients' pathway into case management come from all over the services, and we also accept self-referrals. And for us, our team, the only boundary is one of geography. So if they live outside of our catchment area, we're able to pass on those referrals to the appropriate services outside of our geographical boundary. But following on from that person-centered approach, our team really tries to develop strong support plans that we do in collaboration with our clients. And through that process, we're able to identify what other services that the client would like to work with, or where we can link the client. So we often work with mental health, drug and alcohol services, Aboriginal health services, multicultural health, various hospitals and outpatient departments, sexual health clinics across the district. We also work with Albion Street and Kirkton Road Clinic, various housing providers, GPs, and to those services that are funded under the NDIS and My Aged Care, being OTs, physios, and other therapists. We work with other support workers through different non-government agencies, and we also work with our wonderful community organisations such as the Bobby Goldsmith Foundation and the AIDS Council of New South Wales. So it really depends where the client is at in terms of where they would seek, what they would prioritise that they would need the most support with, and where we can link them in. We do this with the client's consent, and we often attend appointments with clients if that's what they need at that point. And from there, our role is to monitor how they are progressing and bring in a discussion that highlights their physical health needs as well as their psychosocial needs. we aim to assist our clients to become better self-managers of their care, and we walk with them through the complexities as they arise. We also work with Justice Health on a program to support people who are on release from custody. So that's another client group that we also assist.
Great. So with the HIV outreach team, and you say that you work within, the geographical area of Southeastern Sydney Local Health District, how could any of our clinicians today make a referral to your service?
We have a
Very
online,
easy.
we have an online referral process that you could access through. If you are internal through the intranet, you could look up our team, and then you could find our referral form online. Also contacting our team directly and speaking to one of our intake officers. I think they're the main ways to actually for a referral to get through to us. But yeah, we accept them from all over, and we're able to kind of redirect them if they don't fit in with our geographical boundary. We can redirect them to other services that would be appropriate to offer that same case management.
Great. And again, in the spirit of all the information that's going to be provided today, I'll be happy to provide that phone number in the email that will go out to everyone with the evaluation link, bloodborne virus testing policy. And I'm sure the list will continue to grow of resources that everyone's going to receive today. Thank you, Alice and Joanna. So now moving on, I'm going to pose a question to all of our panelists today. But first, I'm going to read a statement from the New South Wales Health HIV strategy from 2021 to 2025. And within that, it states that more than half of the participants living with HIV, 57% in the HIV Future 9 study, reported at least one experience of HIV-related stigma or discrimination in the last 12 months, while 38% of them felt they had been treated differently by a healthcare worker because of their HIV status. Di, from your experience, can you please provide a comment on this?
I've been in hospital a lot lately, having surgeries and different things. And I was quite surprised because overall, most people are informed and healthcare professionals are really lovely and supportive. But a situation popped up which took me by surprise, where I had come in from surgery and I was placed in a room with a woman who had been there for, I think, about a week. And she was from a country area that had come in for her surgery and was preparing to go home the next day. And when I came back, she was very, very chatty and very engaging with me. But the following morning, I called for a nurse because I was strapped into all this stuff and I couldn't get out to go to the toilet of my bed, and I buzzed to get help. And when I buzzed, she took that call and said it was her and that she wanted a cup of tea. And the nurse left and I was left there trying not to wet myself. And anyway, I called out to the lady and I said, please, can you somehow raise attention because you're mobile, so that I can get out of my bed? And she completely ignored me, and I was very confused by what was happening, because this went from a very chatty, overly engaged person to completely not acknowledging me at all. And then she did say to me, they're having a nurse handover, you're not going to get anyone for at least half an hour, and laughed. And I thought, oh, that was a bit mean. Because I mentioned to her I needed to get out of my bed to get to the bathroom. Anyway, I had an accident and I was very embarrassed. And finally, when the nurses came in, I was in tears. The woman continued to be very short-fused. And at one point, she was preparing to leave and have a bath, and she comes up to my partner, my husband, and she says, is it safe for me to use the bathroom or not? And at that point, it suddenly hit me what was going on. During the night, she'd overheard the nurses with the handovers discussing my HIV status and my medication. And for that woman, at that moment, I stopped being angry, and I felt concerned, because I thought, this woman has no knowledge like I do about HIV. She probably has old-fashioned ideas, and this is being driven by fear. And she's quite shocked that she's been put in a room with someone who has HIV. And I don't think anybody had taken this into account. So later I spoke to the staff, and I did notice that the next few times I went back to the hospital, handovers were definitely done very differently. Rather than speaking the word HIV, they would mention with a pen to the area on the clipboard when they were doing their handover, there is also this, and she's taking this medicine for this. So it was never actually spoken anymore. So I'm hoping that that experience and me speaking up helped change that. But it can be as subtle as something like that, which left me feeling terrible and embarrassed. And it also left the woman feeling quite fearful. And I often wonder, did anybody take the time to explain things to her that she was safe being in that room with me?
Yeah. But I'm sure that took a lot of courage to be able to stand up, especially when you were quite unwell yourself and what happened. So thank you for sharing that story with us. Joanna and Alice, can you tell me a little bit about how you guys support your clients around stigma and discrimination when they're encountering healthcare settings?
Our clients would have many examples of how they would have encountered stigma and discrimination, not only within health, but in the wider society. In my experience working with clients, I've found that stigma surrounding HIV is very much internalized. And that's very personal to that client. It's therefore important when we're working with our clients to be understanding about their disclosure to other services and how they would like us as a HIV service to introduce ourselves to other services wherever they would be, whether within health or outside, how they would like us as supporting services to be introduced to those services. Therefore, transparency is important as it helps build trust, but it also raises our awareness of the stigma that is still present for our clients. For example, I have a client who has not disclosed their HIV status to immediate family, but they have consented to that their HIV status being discussed amongst health professionals. For that client, stigma is still has prevented them from seeking the support from family. But because of that fear and judgment and the shame that they would initially feel. Although treatments have come so far to lessen that stigma, for this client, it is still acutely felt, and over time, it hasn't lessened.
Yeah. We also wanted to acknowledge that people living with HIV from other marginalised groups often face sort of multiple levels of stigma from government services. So I guess we're thinking of their, Aboriginal and Torres Strait Islanders, people from cultural and linguistically diverse backgrounds, people who are gender diverse or use drugs, or who've been incarcerated. So they're facing, multiple challenges there often. So some of our clients living longer term with HIV may have experienced very overt discrimination in the past, say in the 80s and the 90s. They may have had that for themselves or maybe for their loved ones. So they, we do hear stories from clients about when staff have double gloved, or when, hospital staff used to leave meal trays out in the corridors because of fear of transmission. So some of those histories are still real and are still felt by positive people. So I guess some of them do have that, we mentioned about internalised shame and stigma about their status, so they may still be fearful about open disclosure, even in a health setting. So it is something to be aware of and not to make presumptions about. So I suppose many of our clients are very experienced consumers, and they're often really highly sensitive to receiving different treatment from staff, so they can pick up very quickly on when they might be receiving a different type of care. So it's also something to be aware of. If a client did raise an experience of discrimination with us, or perceive that they've had that towards themselves. I guess we would try to clarify the events with them to find out more about what happened. We would also consider encouraging them to seek some independent legal advice if that was appropriate, but also to make sure that they're well informed about what the feedback or complaints process might be if they'd like to pursue that option, that they know what their rights are, basically.
Absolutely.
And I was going to love in, if that's right, and say one day, and anyone who's positive from our healthcare system being atrocious with disclosure and failing that, but to put out there for healthcare workers, because we also manage healthcare workers who are concerned about exposure to bloodborne viruses, it's actually incredibly difficult to get HIV off a patient or a client. Standard universal precautions, you treat everyone the same. So there's healthcare workers still get worried, and consumers are, as correctly said by Alice, acutely aware of those slight nuances from a healthcare worker. But we as healthcare workers, it's very, 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 very hard, unless you're doing something that should get you deregistered if you're a nurse, to get HIV off a patient or a client. So treat everyone the same. Standard precautions, gloves when you need to wear gloves, don't wear gloves when you don't need to wear gloves. It's pretty simple.
Absolutely. And just to reflect back on what Alice and Joanna were saying in terms of the internalized stigma, I could imagine, people who live with HIV, due to that internalized stigma, find it incredibly difficult to go to a healthcare setting, and because of that have massive barriers. So to then go into a healthcare setting and face that, I could imagine that could be quite deflating. So a question I'm going to pose to all of our panelists, moving from what Maggie has just said, is what advice would you give our healthcare workers attending today, so that they are providing a space free from stigma and discrimination for people who live with HIV? Maggie, do you want to go back to you?
Yep, sure. I think what Di mentioned before, one of the things as well as, standard precautions, gloves, gowns only when needed, not assumed or based on any presumption about a person's status, especially about HIV, but also curtains. And I'm sure the others can, or Di can talk about this quite well. Curtains are not soundproof. We've been saying this for decades in hospitals and emergency departments. So be aware of the terminology you're using. And as Joanne and Alice said before, if communicate to other healthcare workers discreetly or use a different term. And yes, the great drawing of curtains in an emergency department room or in a ward does not make your conversation soundproof. So just be aware. You don't have to get scared of it, but treat everyone with a bit of respect. And unfortunately with HIV, you're talking, you have a panelist and a person here, we're all very experienced with HIV. So I have no fear of contracting HIV of a patient, but lots of people in public still do. So just be aware of that, but, just treat people with respect.
Absolutely. Di?
I think what Joanna was saying before about perceived stigma also from precursors of bad experiences, they cut very deeply and they stay for a long time. They're very hard to move from people. And I think that when we approach people and we're aware that they're living with HIV, we might find, I often find even myself, I can be very anxious. And when I'm anxious, I find myself acting in a way I wouldn't normally act, or speaking in a way I wouldn't normally act. So I might be a bit curt, I might be a bit abrasive. And that's from fear, basically. And that's that internalized stigma that we're dealing with, which you might not have done anything wrong at all. But it's just being there in that situation, in that moment, raises that for that person. I know one person who's told me that she hasn't told her family, and even in death, her biggest fear is that her family will find out. So that's a very real thing for people. So if we can learn to have a little bit of patience and understand that it's not, might be something directed at us as a clinician, but it might be that person in that moment in a state based from previous trauma and fear.
Di, I'm not sure if you agree with me, but I was going to suggest to everyone, if you're not sure how to speak to a positive patient, or you're not sure like around the terminology, please just ask them openly. They won't mind if you ask, and in fact, they'll probably appreciate your consideration and your respect. So yeah, if you don't know, just ask. Yeah, yeah, consumers are our best teachers.
Agree. Yeah, they'll set the tone for you of what is okay for them in terminology.
Absolutely, and that's really important. Jo?
Oh, yes, my advice would be, I guess from a more of a case management perspective, would be to understand and, work from a trauma-informed perspective, that a client who comes to our services, this might be their third, fourth attempt to engage. So it's important that we offer that access into treatment and to case management, because this time around it might be the more successful pathway. So we want to catch as many people and help them maintain that engagement through our system as much as possible. And yes, and echoing the same advice is talk about disclosure, respectfully ask the difficult questions, and seek consent, because that's the best way to get an honest way of working with somebody.
And you guys have just imparted some really great ideas and information to our healthcare workers attending today. So I hope it's really well received and implemented within the healthcare settings across Southeastern Sydney Local Health District. Well, let's keep the end to this on a nice positive note. And can you briefly, each of you, tell me what is the most rewarding part of caring for people who live with HIV? I'll go to Di first.
Honestly, I've been so blown away by the resilience and the strength that some of these people have endured. And when they share some of their very, very personal stories, it's amazing to think that they can still function today. I find, there's one fellow that comes to my mind right now who has been living with the virus since the 70s, and yet has lost friends, lovers, everything, and has just completed his PhD in social work. And you just sit there and you go, here's a man who's fighting cancer and everything else, but he never stopped living his dreams. And I think that's an enormous thing to meet a person like that. And I honestly feel honoured to be in their presence.
Absolutely. Maggie, what's the most rewarding part of your role?
Yeah, not giving an HIV diagnosis, I imagine, but reassuring a person at that point that it will probably in the few years not be the biggest bit of their life. HIV is very manageable, and being on that journey with people who are quite devastated at first, and then watching them, as Di said, thrive and just flourish with their lives. And truly HIV, 1 tablet a day these days for most people diagnosed, and go off and have HIV, have relationships and have babies and just live their lives where HIV isn't dominating it. And because they've been tested and they know they're on treatment, and just watching that is actually incredibly rewarding.
Absolutely. Jo?
Seeing a client over time sort of regaining that control over their physical health, and we use a lot of tools to help clients stay on top of GP visits and what to ask and what to kind of keep monitoring, and over time working with someone who initially was chaotic or coming to terms with living with HIV, slowly regain confidence and control over their physical health, but also aspects of their everyday life. When that sort of settles down for them and they thrive, that's the most important and rewarding aspect of being a case manager in HIV services.
Great, thank you. Alice, what's your most rewarding part?
As well as what everyone else has said, stolen my thunder. No, I guess apart from working with such a fabulous diverse community of positive people, I think it's also working in a very passionate sector, as you can probably tell. You know, our teams and our services are very, very keen on supporting positive people wherever they can, and just really focusing on trying to support people to improve their own quality of life, basically.
Great.
Yep.
Well, we are running 3 minutes short, so I do have time for one quick question that has come in through the registration process. And I'm kind of burning to ask this question myself, as I find it to be quite interesting. And I'm going to pose this question to both Maggie and Di. Can women with HIV and non-detectable viral loads breastfeed?
Di, do you want to, in 3 minutes, do that one first? I can talk about it clinically and policy-wise, but would you like to answer that?
If I come from, my own lived experience, I had a child while positive. I didn't know at the time. Had I known at the time that I was diagnosed, I would have chosen not to breastfeed that child. But today, 2021, I would like to think that I had an option, and I think other women would like to think that they have an option in how they birth and how they feed their infants. And in my own experience, I breastfed for 3 years. My son's native tongue, the word for breast milk is Nyoni, and he used to call his breast milk Nyoni, and he would tell me, it's not your Nyoni, it's my Nyoni. So I couldn't get him off the breast, and he came out negative. So the risk is still quite small, but it is a risk no matter what. But there are options which I'm sure Maggie will be able to speak to. But coming from other women in Australia, in the Australian context, so 2 organisations that have spoken to this are Positive Women Victoria and NAPWA, which is the National Association of People Living with HIV, which are voices of positive women. And their stand on this is women living with HIV who are taking medications, a combination of antiretroviral treatment, who have a suppressed viral load of under 50 copies throughout their pregnancy and under the care of a supportive and knowledgeable health practitioner, can consider the option of breastfeeding. The other thing is that breastfeeding is safest when most women are supported by a strong healthcare team and have received a clear information and counselling about strategies to prevent their child from having transmission, and to understand culturally what's appropriate for women. We have women coming from Southeast Asia, from African nations, and just by way of not breastfeeding in their community would out them as being HIV positive. And this is a huge issue. And not only that, it's customary, and historically that's what women do. So women living with HIV, I think, should, and so do women in Australia, stand for that they should be supported to make a decision on how to feed their baby without coercion or judgments or legal interventions. From a medical perspective, I know Maggie can answer to that very clearly.
Thank you, Di. I'll do it very quickly because I think we're almost up, but thank you. You basically said it all. And the policy around breastfeeding, the national and state policies are still, yes, a woman should be on treatment undetectable, support them. It still doesn't recommend it, but as clinical services, we work with our clients and partner with them because basically there just hasn't been enough evidence and research on it. So at this point, it's not fully endorsed, but considering it, which is a very ambiguous answer. But I actually fully concur with what Di said. We're there to help each other with this one.
And the benefits here are the advice is no more than 6 months, mum on treatment, bub on treatment. So it's a full team service. You know, the paediatrician, HIV paediatrician has to be taking care of bubby's interests, HIV specialist taking care of mum's interests, and hopefully we have a positive outcome in that everybody is safe.
Great. And Di has kindly given me access to 2 documents that I can share with all of our participants today. And again, they will be attached to that email, that growing list of resources that we're getting out to you guys. So I'd like to say a massive thank you to all of our panelists today for being a part of the World AIDS Day HIV caring and understanding, and geez, you guys care and understand. So thank you for all of your hard work. I'd like to thank all of our participants for taking part in today, and also Stephanie McFarlane for helping us with our tech support, and my manager Priyadi for giving me a lot of support to get through this as well. So like I say, we're going to flick up a link to our Survey Monkey for some feedback. Please be brutally honest in your feedback. If you're not, I'm not going to know what I need to change for future webinars. And again, this will be emailed to you again in the coming days, along with all those lovely resources that we've gotten out there. So thank you again to all of our panelists and all our participants today. And again, remembering those who have lost their lives from age-related illnesses. Thanks.
Thank you, Maria, for hosting us. We really appreciate it.